So I'd like to start by thanking the steering committee for considering our research for presentation at this meeting. So the topic that we are addressing is the role of medicinal cannabis in the management of chemotherapy-induced nausea and vomiting. And it's a great privilege to be able to present on behalf of my colleagues at the NHMRC Clinical Trial Centre, the Chris O'Brien Lifehouse and the Lambert Initiative at Sydney University, the results of the first phase of our Cannabis CINV study, which is a crossover phase 2 randomised placebo-controlled trial evaluating an oral THC CBD cannabis extract in the management and prevention of refractory chemotherapy-induced nausea and vomiting, which is CINV for those who are not familiar with the acronym. So I'm presenting these. Peter Grimmerson is an oncologist at the Chris O'Brien Lifehouse, and he presented these results at the 2020 ASCO meeting, which happened last month. And I should say I'm a medical oncologist also from Sydney, and my role in relation to this study is I'm the Trials Fellow at the NHMRC Clinical Trial Centre. So chemotherapy-induced or nausea and vomiting is quite a common and feared side effect of chemotherapy. And fortunately, there have been quite substantial improvements in the way that we prevent and manage nausea and vomiting in patients receiving chemotherapy. So there are quite a few active medications which we use in guideline with guidelines in combination to prevent nausea and vomiting. So this typically consists of the corticosteroid dexamethasone in combination with a 5-HT3 antagonist and possibly a neurokinin 1 antagonist. And more recently, there's emerging evidence showing that olanzapine, which is an antipsychotic, also has anti-nausea effects. And these are recognized in clinical guidelines in the prevention of nausea and vomiting around the world. However, despite this, the use of these combinations of preventative medications, up to half of patients receiving highly or moderately emetogenic chemotherapy will still experience nausea and vomiting, so it is an area of unmet need. There's been substantial community interest in exploring medicinal cannabis for various indications. And one of these indications is the prevention and management of chemotherapy-induced nausea and vomiting. However, it's largely based on anecdotal experience or what I would consider to be outdated studies, which either showed limited efficacy, showed some significant adverse events at the doses required to control nausea and vomiting, or were generally underpowered and compared the medicinal cannabis or cannabis against outdated anti-emetic regimens. So there really is a need for more evidence in this area before it can become standard practice. There is some preclinical evidence to suggest that CBD-rich preparations may be effective and better tolerated than their THC-only counterparts, and this is due to the counteracting the psychiatric effects of THC and also the anxiolytic properties of CBD. There was a very small randomized trial which included 16 patients in a similar population to this study, that is people with refractory chemotherapy-induced nausea and vomiting. This study used a buccal spray THC CBD 1-to-1 formulation, and it was added to a standard anti-emetic regimen, so a very similar design to this study. And this study reported some very interesting results and was certainly very promising in terms of the activity signal, with 71% of patients having a complete response for chemotherapy-induced nausea and vomiting compared to 22% in the placebo arm. And it was also quite well tolerated, but there were some transient neuropsychiatric type side effects that we would expect to see with this medication. However, this was a very small study, so it's not really practice changing at all. So the aim of the Cannabis CINV study is to evaluate an oral cannabis extract in, as a secondary preventative for chemotherapy-induced nausea and vomiting. And the study drug that was used is a proprietary formulation by Tilray. It is a cannabis extract, and it comes in capsules which contain THC and CBD 2.5 milligrams of each, so a 1-to-1 ratio. And it's dosed 3 times per day. And this was really an attempt to mimic the pharmacokinetic profile of nabixmols, which was the buccal spray that was used in the previously mentioned study. So the dosing schedule, the treatment was given over 6 days, each chemotherapy cycle. So starting the day before chemotherapy, and then 3 times a day for day 1, day 2, day 3, day 4, and then on day 5 stopping with a midday dose. Within the study protocol, participants were able to self-titrate the number of capsules that they took based on their experience of nausea and vomiting, and also experience of side effects from the medication. So patients typically, they started with just 1 capsule, and they were able to work up to a maximum of 4 capsules at each dosing time point. So that in total, a maximum dose in a 24-hour period could be 12 capsules or 30 milligrams. So this is the schema for the combined phase 2/3 trial design. And so the phase 2 component is the part that has been completed and for which we have results. And you can see that it has a crossover design. So at the beginning, patients are randomized for their first cycle of chemotherapy to receive either the study drug or placebo in a blinded fashion. And then they switch over without unblinding for the second cycle, referred to as cycle B. And at the end of cycle B, the participants are asked to report a preference for which cycle. And then if they were having further chemotherapy, they would have their preferred either study drug or placebo, again blinded for the cycle C. And then their time on the study was complete. The phase 3 component, which is currently recruiting, is a parallel design trial and is recruiting another 170 patients. And this is really to investigate the longer term efficacy over multiple chemotherapy cycles. So in total, the definitive trial contains 250 patients, and it will use the between patient comparison over cycle A as the primary endpoint. So for this, here I'm actually reporting the results from the crossover phase 2 component, which is a within patient cycle A and B comparison. So to be eligible for the study, patients had to be adults. They could have any malignancy of any stage. So this is both in the metastatic setting and also in the adjuvant or curative setting. They needed to be receiving a type of intravenous chemotherapy that was known to be moderately or highly emetogenic. And they needed to require at least 2 more cycles of that same chemotherapy and have experienced nausea and vomiting related to chemotherapy in a previous cycle. Chemotherapy that involves an oral chemotherapy agent was not permitted. If patients were having radiotherapy, which can also cause nausea and vomiting, were not permitted. And if patients had nausea and vomiting related to their disease, that was also not permitted. The primary endpoint for the study was the proportion of patients with a complete response. And for those who are not familiar with that endpoint, it means no vomiting and no use of rescue medications. And it actually doesn't include a measure of nausea in it. So that one of the key secondary endpoints for this study was nausea control. And those, for those who understand statistics well, the 80 patients in this phase 2 component of the study provided 80% power with a 2-sided p-value of 0.1. to detect a 20% difference in complete response. So the 81 patients were recruited between 2016 and 2019. And for the efficacy analysis, 72 participants who completed both cycles of cycle A and cycle B were included. And in the safety analysis, 78 patients were included. And there were 3 participants who actually withdrew their consent after enrolling in the study. So we don't have safety or efficacy data for them. So 265 participants were screened for eligibility across 10 sites in New South Wales, and 184 of those were excluded. Now, the commonest reason for exclusion was not meeting the eligibility criteria, but also there were a significant number who just refused to participate, and perhaps that relates to the fear of stigma and just not wanting to be involved in a medicinal cannabis trial that Justin alluded to earlier. However, another important reason for not participating in the study that was identified was not being able to drive. And I believe that's been covered elsewhere previously. So 81 participants were randomized. There were 40 who received the investigational product in cycle A, and there were 41 who received placebo in cycle A. And 3, as I mentioned earlier, 3 patients withdrew consent. There were no patients lost to follow-up, and there were 6 patients who discontinued treatment early for the reasons which are listed there. So 4 in the medicinal cannabis arm and 2 in the placebo arm. So what that means is there were 35 participants who received both cycle A and B in the medicinal cannabis arm and 37 in the placebo first arm. And they were included in the efficacy analysis. And of the 78 patients who didn't withdraw their consent were included in the safety summary. So this table summarizes the baseline characteristics of the participants in the study. And so the key things to point out here have little asterisks next to them. So in terms of the age distribution, almost 2/3 of participants were between the age of 50 and 69. And that really just reflects the age at which cancer incidence is at its highest. 78%, so the majority were women. And that also it reflects the type of cancers that we treat with the most emetogenic chemotherapy. So you can see that breast cancer, 1/3 of participants had breast cancer, which is treated with this combination, doxorubicin plus cyclophosphamide. And a little over half of participants had prior cannabis use, and that could have been at any stage in their life in any form. Other common malignancies for which people were able to participate in this study included colorectal cancer, lung cancer, and other gastroesophageal cancers. There was a mix between people receiving curative treatment and palliative treatment, about 50-50. And the majority of participants were having their first line of chemotherapy. Again, that's probably skewed because of the prevalence of breast cancer patients in this part of the study. It's about 50-50, the split between moderate and high emetogenic risk chemotherapies, and you can see the commonest types there. An important thing to note, only 3 participants out of 81 or out of 72 were using olanzapine in their chemotherapy-induced nausea and vomiting prophylaxis. And some would say that if we repeated this study today, that number would be quite a lot higher. And just a reminder, in order to participate in this study, participants had to have experienced significant chemotherapy-induced nausea and vomiting during a previous cycle of chemotherapy. And what that means is either they vomited, or they had significant nausea, or they needed to use rescue medication such as Maxolon to control their nausea. So here we've got the key results. So the primary endpoint, which is complete response, which again means the absence of vomiting and no use of rescue medications, there was an improvement in the proportion of patients who had a complete response to 25% from 14% in the placebo group. So that's an absolute difference of 11%. And it was statistically significant with a two-sided p-value of 0.04. And on the right here, you can see that represented graphically. There was a similar trend in the other secondary endpoints, including no vomiting, no use of rescue medications, and no significant nausea, which meant a score of less than 2 out of 10 on a 10-point scale. And also in terms of complete response to nausea, although this one was not statistically significant. So there was formal testing performed to assess the potential for period or carryover effect, and none was detected. At the end of the second cycle of treatment, this is the self-reported tolerance. So participants recorded a diary, which they were contacted by the study team for the first week of treatment, so that we were sure that participants were adherent to their treatment, were able to self-titrate their medication as required, and also recorded the adverse events that they experienced. And this was a medicinal cannabis specific checklist that participants recorded their side effects in. And as you can see, there was quite a large increase in the moderate or severe rates of sedation or dizziness that were experienced by patients, but reassuringly, there were no issues with hallucinations or palpitations for patients receiving medicinal cannabis. Now, in terms of serious adverse events in the study, as you would expect in patients with cancer who are receiving chemotherapy, there were serious adverse events, but none of these were attributed to the medicinal cannabis. So overall, it did not add significantly to the serious adverse events experienced by participants in this study. At the end of cycle B, participants were asked, when factoring in both the control of nausea and vomiting and also the experience of side effects, which cycle of treatment they preferred, without knowing whether they had the active agent or placebo. Overwhelmingly, participants preferred the cycle of treatment that contains medicinal cannabis, with 83% of participants reporting this way, and only one person who elected not to give a preference. So a summary of the findings of this study, which were presented at ASCO, was that the addition of an oral THC CBD extract to guideline consistent anti-emetic prophylaxis was associated with less nausea and vomiting, but it had additional side effects. And the majority of participants preferred the medicinal cannabis over placebo. The strengths of this study are that it included modded guideline consistent anti-emetic experimental and control arms. The crossover design allowed preference to be measured, and also is a very good way of correcting for within patient differences in baseline characteristics. And there was also excellent compliance of participants in completing the patient diary, so that was over 90%. The limitations of this study are that it was an enriched population, which limits comparison with other studies, such as the olanzapine study. Few patients received olanzapine, which is many would argue is now a standard of care, at least for certain chemotherapy regimens. And many refused to participate for various reasons, which we've covered. The other limitation, of course, this is a phase 2 crossover design, so it's not statistically powered to demonstrate efficacy or change practice. So the implications of this study is that the results of this are really intended to guide further research. So the small sample size and crossover design may compromise allocation concealment, and the phase 3 parallel component of the study is really required to confirm the efficacy and also to provide further information on the long-term effectiveness, cost-effectiveness, and tolerability over multiple cycles of treatment. So based on the results of this study, the IDSMC has allowed us to continue into the phase 3 component of the trial, which will recruit an additional 170 patients. And the second important implication of this study is that it shows that crossover designs in randomized trials are a useful way of looking for preliminary efficacy signals in anti-emetic studies. So what are my thoughts on the implications and further considerations for these results? So I think this demonstrates that this oral THC CBD extract is active, and it's certainly well tolerated for this indication. We need more information in terms of the efficacy and also the cost of these types of medications. And we also lack information on where this medication should sit in the therapeutic hierarchy. And in particular with the availability of olanzapine, which has been shown in a phase 3 randomized study to provide very significant improvements in control and prevention of nausea and vomiting, and comes at a fraction of the cost without the driving restriction implications. Of course, the legal considerations on being able to drive and operate heavy machinery under whilst using such medications is also important. And then thinking more broadly about the potential role of these medications in the non-chemotherapy-induced nausea and vomiting population. I think it's really not appropriate to be extrapolating from this study results into that population. And really this is because we know that the mechanisms of nausea and vomiting are quite varied and complex, and actually there are well-proven alternatives which target various parts of the nausea and vomiting mechanism. So lastly, I want to acknowledge the investigators and staff at the sites in Australia who participated in this study. There's a list of all of the hospitals and the investigators who participated. The participants and their families, of course, and I didn't say this at the start, I meant to. This was a New South Wales Health funded study, and it was a collaboration between the NH&MRC Clinical Trial Centre, the Chris O'Brien Lifehouse and Lambert Initiative. And of course, the drug was provided by Tilray, but no funding or involvement in any of the analyses or manuscripts was provided. So that's the end of my presentation. And thank you very much for the opportunity again to speak, and I'd be more than happy to answer any questions as best I can.